So next is enterocutaneous fistula, and it's V14. How is ECF classified? What are the common causes? So enterocutaneous fistula is classified on the basis of output. If it's more than 500 ml in 24 hours, it's high output. If it's between 200 and 500 and 24 hours, it's moderate output, and if it's less than 200, it's low output. By organ: type 1 gastric and esophageal, type 2 small bowel, type 3 colonic, and type 4 atmospheric. Causes: 75 to 80% is iatrogenic due to trauma, iatrogenic intraoperative trauma, and anastomotic leak, and spontaneous 15 to 20% inflammatory bowel disease, malignancy, radiation, and appendicitis, diverticulitis, actinomycosis, tuberculosis, radiation, and ischemia. What are the factors which favor the spontaneous closure of an extracellular fluid? Extracutaneous fistula. So factors which favor is low output fistula. It's iatrogenic appendicitis or diverticulitis, no distal obstruction, no surrounding collection or inflammation, and fistula tract length more than 2 centimeters, and no foreign body. And not favorable if it's due to the inflammatory bowel disease, malignancy, radiation, if patient has distal obstruction, if adjacent infection or inflammation, high output, and lateral or multiple fistula, tract length less than 2 centimeters, and foreign body like the mesh. How would you manage a patient with an ECF? This approach to a patient with enterocutaneous fistula can be guided by the SNAP principle: sepsis, nutrition, assess anatomy, and the procedure. So sepsis, main cause of the mortality from enterocutaneous fistulas are the sepsis. So broad spectrum antibiotic, cross-sectional imaging to rule out any collection which it needs to drainage, and nutrition. Adequate levels of nutrition have been shown to increase the role of fistula component closure. If possible, use the enteral route. If not, then long-term TPN. Anatomy: define fistula not be using the modalities such as CT, fistulography, and small bowel follow through, or MR enterography, to insert the location of segment involved in the enterocutaneous fistula and relationship with the surrounding structures. And then procedure: 1. Sepsis control and adequate nutrition established. Minimum time: wait for 6 weeks, let the inflammation settle. And principles of definitely operation are abdominal entry, extensive duodenal resection of the enterocutaneous fistula, and anastomosis, proximal defunctioning, stoma in some instances, abdominal wall reconstruction. And I also do with the SNAP protection of the skin. P, protection of the skin. Thank you.